Hello, I'm Dr. Tuya. Today I'm attending the American College of Cardiology conference where I have the incredible opportunity to connect with some of the world's leading cardiovascular specialists. It's an inspiring environment filled with groundbreaking advancements in diagnostic techniques and innovative treatment options in cardiology. Throughout the day, I've had insightful conversations with the top experts, exploring cutting-edge technologies and best practices that are shaping the future of cardiovascular care. I'm excited to bring these valuable insights back to my community and continue supporting health and wellness with the top up-to-date knowledge in the field. Thank you.
All right, so we have Dr. Nicola. So,
hello. The new field of cardio-oncology.
Great.
And, I am here to present the research of our institution, of my department, and especially the cardioprotection with semaglutide and with vericiguat and with inclisiran against the cardiotoxicity of anthracyclines and other cancer drugs. And also another field in which we work is the cardioprotection by SGLT2 inhibitor as dapagliflozin against toxicity from biological drugs, always in cancer.
yeah, that's great. So, do you think the dynamic of the patients in Italy and the dynamic of the patient in America, do you think are this pretty same, or
No,
when it comes to the obesity, what do you think?
The obesity is a big problem because it's a risk factor for both cancer and for cardiovascular pathologies. In the case of cardio-oncology, I think that semaglutide could be very useful in the prevention of metabolic syndrome that is linked to cancer, and also in the prevention of cardiovascular toxicity that are linked to risk factor, to cardiovascular risk factor. And if you treat cardiovascular risk factor, if you decrease your weight, you decrease cancer and you decrease also the incidence of cardiotoxicity in cancer.
So what about the cardiovascular risk factor, mortality risk factor in Italy, compared to like other countries?
It's the same.
General
The situation is the same. I think that in the United States it's worse because in the United States there is more people and higher percentage of people with obesity and overweight.
Exactly, yeah.
And so there is more cancer and more cardiovascular disease.
But do you think that the obesity related to cancer?
Yes, obesity. Overweight and obesity is a risk factor for cancer. It is well known.
Yeah, I agree with you. All right,
And obesity is and overweight is a negative prognostic factor also in the prognosis for cancer, after the diagnosis of cancer. Cardiovascular cancer is primitive cardiovascular cancer is rare. The secondary cardiovascular cancers are more frequent. It's more frequent for metastasis from, for example, melanoma is lung cancer and other cancer. But the problem is that cardiotoxicity is the cardiovascular pathology. The first of all is heart failure. Secondary to the cardiotoxic effects of cancer drug.
exactly.
This is the problem.
Like example,
Much
dimacizumab, all this trastuzumab.
Trastuzumab is the most famous cardiotoxic drug because it was the beginning of cardio-oncology. It was the beginning of the 2000 years.
Yeah.
And trastuzumab has changed the history of a more aggressive cancer, HER2 positive cancer. 25 of breast cancer patients are HER2 patients, so they need the trastuzumab. And trastuzumab can give a heart failure, can can cause a decrease of ejection fraction, especially after the anthracycline treatment.
Yeah. All right. Thank you so much, Dr.
Thank you.
Nikova, and nice talking to you.
Thank you. Bye-bye. So,
All right, so we have a Dr. Waits, Master of American College of Cardiology, which is the highest level. All right, so we're gonna hear what he's going to present today in this conference.
So I'm part of the Health Equity Committee of the American College of Cardiology. It started as a work group, but now we're officially a committee that looks at health equity. Our motto is that we're doing health for all, and this is what we're all about with health equity. And I'm on the panel today to discuss how we're doing this, and a lot of this will be about community health workers and about how we incorporate them into the health of a state. So I'm in the state of Mississippi, and of course we have a division all over the nation of states, and my state is the one that has the worst health numbers of all at this point. So we have a lot of work to do, and we think community health workers would be very beneficial in doing that.
All right, thank you so much, Dr. Waits.
Yes,
Thank
nice
you.
to talk to you.
Thank you.
Yeah, you're sure.
Okay, so we have Dr. Melina here.
So hypertensive disorders of pregnancy, such as preeclampsia and gestational hypertension, can increase the future risk of cardiovascular disease for the mother. And so we developed a postpartum hypertension clinic where patients come in and they see both a cardiologist and maternal fetal medicine specialist to really help optimize their postpartum care and lower cardiovascular risk factors. So in this study, we aim to describe our clinic population that we saw in the first 5 years, as well as compare a group of clinic patients versus a group of people who didn't attend our clinic. So we ended up finding in our total clinic group, we recommended every patient who came to our clinic to receive a lipid panel, an HbA1c, and to follow up with their PCP within a year postpartum. We ended up finding that around 45% of our patients followed up for all three of our objectives. For our comparison analysis, we ended up making a control group of patients who didn't attend our clinic and compared them to clinic patients, and we ended up finding that significantly more of our clinic patients completed the recommended follow-up as opposed to those who didn't attend the clinic. Rates were still, they weren't great, but they were still around about 30 to 40% of follow-up, which for the postpartum period is pretty good overall. So I think overall this study really just shows that postpartum hypertension clinics can really help to optimize postpartum care. However, there is still a lot of work to be done in the realm of postpartum care.
I see. Thank you, Dr. Melina.
Thank you.
I appreciate it. All right, so we have Dr. Alia Hatman. So she's actually discovered how she used a DigiFab in an AKI patient. So she's going to tell us a little bit about her presentation.
Hi, thanks. This is my poster. So we had a patient who came in with digoxin toxicity. She was on digoxin for her heart failure, and she came in extremely altered, a lot of distress, and had some life-threatening arrhythmias. So she was given DigiFab on her first day of hospitalization to bind the digoxin. She recovered well from her initial toxicity, and then on hospital at day 3, about 84 hours into her stay, she started having the same symptoms, and her EKG showed digoxin effect. So we thought this was a recrudescence of her digoxin toxicity, which can happen. So essentially what happens is as your digoxin and your DigiFab make fragments and bind, if you have a renal injury like our patient did, it will not clear your DigiFab, and that will allow the digoxin and the FAB fragments to dissociate and can give you a rebound in free digoxin levels. This is a known phenomenon, but usually this rebound is not clinically significant, but in our patient it was. So because of this, we gave her one additional vial of DigiFab, and her symptoms and her EKG findings resolved after this additional vial, and we discontinued digoxin for this patient going forward.
Okay, that's great. So the patient recovered. You saved the patient.
Yes, she recovered. She just cannot be on digoxin anymore. So
Great. All right. Thank you, doctor.
So recently, a big meta-analysis on Lancet journal coming out to see the effectiveness of